So in this lecture, we'll talk about the tuberculosis, which is a very important topic from university exam point of view. And in this lecture, we will talk about the causative agents of the tuberculosis, the exact pathogenesis, which will be helpful in both microbiology as well as in the pathology. And at last but not least, we'll talk about the clinical features of the tuberculosis, using which you can diagnose the cases of a clinical scenario. Nowadays, there is a trend of asking the question in clinical scenarios. So only if you know the clinical features, then you can diagnose the those cases. So we will talk everything in a sequence, first starting with the causative agent. Suppose you have got a question or a clinical scenario which is suggesting you that it is a case of tuberculosis, then they will first ask you what is the causative agent of this disease. So in that case, you have to write as the Mycobacterium tuberculosis complex. Remember, you should not write Mycobacterium tuberculosis only, because that is not only the bacteria which is causing the tuberculosis. There are other bacteria, other mycobacteria also which can cause this tuberculosis. So you should always write Mycobacterium tuberculosis complex, not only Mycobacterium tuberculosis. And after writing Mycobacterium tuberculosis complex, you have to utter, or you have to write these some of these examples like Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanum, Mycobacterium microti, and the Mycobacterium mungi. So these all names should be written after that. So first you have to write Mycobacterium tuberculosis complex. Now the question arises that why they are called as a complex. This is because they are genetically related to each other. Okay, so because they are genetically related to each other, and plus they all have the potential to cause the tuberculosis, similar type of tuberculosis. That's why they are together called as the Mycobacterium tuberculosis complex. So whenever they ask you the causative agent of tuberculosis, you have to write the Mycobacterium tuberculosis complex, not the Mycobacterium tuberculosis only. Okay. So after understanding this fact about the causative agents, next we will talk about the pathogenesis. So coming to the pathogenesis, we know that tuberculosis, the mode of transmission of tuberculosis occurs by the aerosols, okay, by droplets. So and by inhalation. So inhalation of the tubercle bacilli by the aerosols is the mode of transmission of the tuberculosis. So once there is inhalation of those tubercle bacilli, then those bacilli enter into the lungs, and there occurs the opsonization of the bacilli by the complement protein C2A and C3B. Now, out of these, the C3B complement protein is more important than the C2A complement protein. Uh, but here the question is, what is this complement proteins and what is opsonization? Now, for the time being, you just remember that there occurs opsonization of the bacilli by C2A and C3B complement proteins. Once we will start the immunity chapter of the microbiology, then you will understand what is opsonization and what are the complement proteins. These complement proteins are very important part of our immunity. Okay, they play a very important and very major role in our immunity. So we will come to know about all of these terms once we start the immunology. Now, so as there has occurred the opsonization of this tubercle bacilli in the lungs, then after opsonization there occurs the phagocytosis by the macrophages. Now these macrophages, what do? They crush the bacteria inside them, okay, and break the bacteria into different antigenic fragments, and then load these fragments over their cell membrane and present these fragmented antigens to the helper T cells. So suppose this is a macrophage and this has taken this bacteria, then this bacteria breaks down. I mean, this macrophage breaks down this bacteria into this breaks down this bacteria into multiple parts. Like this is a part, this is a part, this is a part, this is a part. Okay, and then what happens after that? After that, it expresses it expresses these bacteria over its surface in this way. This is one antigenic fragment, this is another antigenic fragment, this is another antigenic fragment. So it is expressing these fragments over its surface. Now a- another and whom does it express? So it expresses it to the T cells. Okay, so suppose this is our T cell, this is our T cell. Okay, and they are expressing this to the T cells. These are the receptors of the T cells, and these are expressing these antigenic fragments to the T cells. Now what happens to these T cells? Once they get exposure to these antigenic fragments over the macrophages, then these T cells these T cells get converted into the type 1 helper T cell and type 2 helper T cell. Okay, and the pathogenesis now, real pathogenesis now begins here. So once there is activation of the type 2 helper T cells, first we will talk about the type 2 helper T cells because that part is very small. So once there is activation of the type 2 helper T cells, then these type 2 helper T cells release the interleukin 4 and interleukin 5. Now we all know that the interleukin 4 and 5 are responsible for activation of the humoral immunity. And in the tuberculosis, the role of the humoral immunity is very minor. That uh, does not play a major role in the tuberculosis pathogenesis. So that's why we will not much concerned about this part of the pathogenesis. Okay, because the humoral immunity is not playing such a great role that needs to be talked. Okay, about in this lecture. So we are more concerned about the type 1 helper T cell, which is going to activate the cell mediated immunity and is going to play the major role in the pathogenesis of the tuberculosis. So we are more concerned about the type 1 helper T cells. This type 1 helper T cells release the interleukin 2 and interferon gamma. So as there is release of interleukin 2, then that activates the monocytes and macrophages, and hence they cause the macrophage activating response. So now this is the first point that you should remember in the pathogenesis, that they are going to activate the macrophages, and then there begins the first step of the pathogenesis, which is the macrophage activating response. This is the first part of the pathogenesis. We will see the second part later on, but the real pathogenesis is from here. Okay, after the helper T cell activation, type 1 helper T cell activation, then the activation of the macrophages, and then the beginning of the macrophage activating response. So this interferon gamma activates the alveolar macrophages. What are the alveolar macrophages? The macrophages which are present in the lungs, they are called as the alveolar macrophages. And then after that, there is activated macrophages undergoing some of the structural changes. These activated macrophages undergoing the structural changes, and they form the epithelioid and giant cells. These activated macrophages undergo the structural changes, producing epithelioid and the giant cells, and then these cells aggregate to form the granuloma. I know you must have known, you must be knowing about the epithelioid and the giant cells because they form the granuloma, and the same granuloma is here also in microbiology. So there is no difference in the granuloma or the tuberculosis, in the granuloma of the microbiology or the pathology. The granuloma is same here also. So these granulomas are formed by those activated macrophages, which are forming the epithelioid and the giant cells, and further on those epithelioid and giant cells are forming these granulomas. Now in the granuloma, we know that these giant cells and epithelioid cells are not alone. They also have the fibroblast and the lymphocytes in the granuloma. Now the question is, how does this lymphocytes or fibroblasts come to the granuloma? So the answer to that is these epithelioid cells and the giant cells, they secrete the interleukin. They secrete interleukin 1 and interleukin 12. Now this interleukin 1 and interleukin 12 attracts the lymphocytes. That's why we see that in the granuloma uh, at the central part there is the giant cells and the epithelioid cells, then surrounding that is the lymphocytes, and surrounding that is the fibroblast cells. So So first of all, there is formation of hard tubercle. First of all, there is formation of the hard tubercle. Hard tubercle means still there is no necrosis at the center. We have read in the pathology that at the center there is a central necrosis, but before the presence or before the occurrence of those that central necrosis, there does not occur any central necrosis. So initially it is always a hard tubercle. In pathology we read a simplified version, okay, that is in the later stage version, that is a later stage of the disease. We read in the pathology that there occurs the central, that there is a central necrosis. But in here we uh, now come to know that initially there is no necrosis at the center, and that is called as a hard tubercle. That hard tubercle has epithelioid and the giant cells at the center, surrounded by the lymphocytes and fibroblasts, and no necrosis at the center. The necrosis will occur later on. We will see how does that occur. So still we are continuing the macrophage activating response. Okay. So after the formation of the hard tubercle, then what happens? Later on, what happens? The central cellular zone, which is formed by this epithelioid and the giant cells, these undergoes caseous necrosis. These undergo caseous necrosis, which is characterized by cheesy appearance. Now, you all remember how does that caseous necrosis formed in the pathology. Okay, so initially there was no necrosis. It was formed only after hard tubercle has formed. Okay, and once there is appearance of this caseous necrosis at the center, now it is called as the soft tubercle. Now it is called as soft tubercle. So there occurs the soft tubercle formation. So after the central caseous necrosis, the tubercle bacilli growth is inhibited at the center. Why? Because there is low oxygen and low pH. So that is the feature of the soft tubercle formation, and that is how these granulomas are preventing the spread of this tubercle bacilli in the body, because they are entrapping those bacilli at the central part of those granulomas, where there is low oxygen tension and there is low pH, which is preventing the growth of those tubercle bacilli in those granulomas, and thereby preventing the spread of these bacilli to different other organs of the body. So that is why the bacilli remain in the dormant state in the body after the soft tubercle formation. So this was all about the first part of the tuberculosis pathogenesis. Now begins the second part. The second part is the tissue damaging response. Okay, the second part is the tissue damaging response. Tissue damaging response. So how does that begin? So the tuberculosis, the exposure to the tubercle bacilli has occurred earlier, and now there has been formation of soft tubercle, and the bacilli are in the dormant state. Till now it is all clear. Now begins the tissue damaging response. How does that tissue damaging response begin? So whenever there is immunosuppressive state in a patient, then there is beginning of the tissue damaging response. So by this we come to know that the tuberculosis, why the tuberculosis is a latent infection. Okay, and when there is immunodeficiency, then this latent tuberculosis becomes evident. Okay, so what is the immunosuppressive state? So immunosuppressive states are the old age, HIV infection, steroid therapy, and the organ transplantation, diabetes mellitus, plus the immunosuppressive drugs. These you can remember, these are all the immunosuppressive states. And when there is a immunosuppressive states, then what happens? The macrophage activating response becomes weak. We have talked about the macrophage activating response, like how does those macrophages were getting activated, producing epithelioid and giant cells, then producing hard tubercle, and then producing the soft tubercle, and then in the soft tubercles the caseous necrosis. How that caseous necrosis was preventing the growth of the tubercle bacilli by low oxygen tension and low pH. So Now these all process has become weak. So that's why in the immunosuppressive state there begins the evident, the tuberculosis infection becomes evident, okay, because the tubercle bacilli are now not remaining in the dormant state. There is no one to prevent them from growing, because there has not been the formation of the hard tubercle and the soft tubercle, okay. So now in the immunosuppressive state, these macrophage activating response becomes weak, and hence the body manages the infection by delayed hypersensitivity reaction. Now this is also such a term which you will understand once I start the hypersensitivity lecture. Okay, so till now you just remember that there occurs delayed hypersensitivity reaction. We will understand it together when I start the immunity lectures. So since this macrophage activating response is not sufficient, is not uh, able to prevent this tuberculosis infection, and this macrophage activating response is weak, so that's why body is now responding with a different mechanism, that is delayed hypersensitivity reaction. And we know that hypersensitivity reaction always cause some of the damage to the body also, because they are hypersensitive, that means they are more sensitive, okay, and they cause damage to the body as well. So these hypersensitivity reaction is the cause of the tissue damage, and that's why it is called as the tissue damaging response. Now when there occurs the tissue damage due to that delayed hypersensitivity reaction of the body, then this gaseous necrosis becomes liquefied, releasing the tubercle bacilli. We have learned earlier that when the immunity was good, then there was a formation of hard tubercle, soft tubercle, and in the soft tubercles the bacilli were in a dormant state, in a latent state. Now when this immunity has fallen down, then this response of macrophages has diminished, and the body is now responding to the delayed hypersensitivity reaction, which has started causing the tissue damages. And under the influence of the tissue damages, there is also occurring the caseous necrosis liquefaction. Okay, so now the caseous necrosis is no more able to keep the bacilli, tubercle bacilli, in a latent state, in a dormant state. So what is happening after that? So as this there is a liquefaction of the caseous necrosis, there occurs then there occurs the appearance of the symptoms. Now the symptoms start appearing, because now there is no one to stop the tubercle bacilli. The tubercle bacilli are free now, okay, and also spread begins now. Why? Because the tubercle bacilli have set free, okay, they are not now behind the bars, they are now free. So that's why they start spreading also. How does this spread occurs? That is by coughing and sneezing to other people, and they are also over spread inside the body also. Now that spread is by the hematogenous and lymphatic spread, and that to the different organs. So we have learned how the infection is creating symptoms, and how the spread is also getting evident here. So spread is occurring to the other people by coughing and sneezing, while spread is occurring to the same person body's different organs by the hematogenous or the lymphatic spread. While when the symptoms when the bacteria are set free, then there appears the symptoms also. So this is the whole pathogenesis, right, from the entry of the bacilli in the human body by inhalation, till the appearance of the symptoms and the spread to the other organs of the body. Now we will start the clinical features. That is the last part of this lecture, but not the least. This is an important point of this video, because you will understand, or you will find you will be able to diagnose a case only if you know the clinical features of a particular disease. So the clinical features of the tuberculosis: can be classified into the pulmonary tuberculosis and the extrapulmonary tuberculosis. That means the tuberculosis, if it is affecting only the lungs, then it is pulmonary tuberculosis, and if it affecting some other parts of the or some other organs of the body, other parts of the body, then it is extrapulmonary. Extrapulmonary means outside the lungs. Okay, infection, TB infection. So if it is a pulmonary TB, generally they will give you a case of pulmonary TB only, not the extrapulmonary TB. So you have to know these symptoms to diagnose a case of pulmonary TB in the exam. So the pulmonary TB is characterized by some of the important clinical features, like there will be fever. Okay, fever will be generally night sweats, night, not night, then evening sweats. Okay, I mean evening rise of temperature will be there. Okay, that is the fever characteristic of the fever. Then there will be productive cough. There will be sputum getting produced in the cough, and then there will be evening rise of temperature, as I have already mentioned, and plus there will be hemoptysis. Why hemoptysis? Because in this tuberculosis there occurs erosion of the bronchial vessels. Okay, and after the erosion of the bronchial vessels, the blood appears in the sputum, that is called as hemoptysis. Plus there occurs night sweats. Okay, night sweats also occur there. Plus there will be a history of significant weight loss, and pleuritic chest pain can also occur there in the pulmonary TB. So suppose if you are given a case that that a 56-year-old male comes to your OPD with a productive cough and evening rise of temperature and hemoptysis, then what is your clinical diagnosis? Then right at then you have to diagnose it is a case of tuberculosis, pulmonary tuberculosis. You cannot do a mistake. This is a typical finding in the pulmonary TB. Evening rise of temperature, hemoptysis, productive cough. These are typical features of the pulmonary TB, and this you know only if you know the clinical feature of that disease. So that's why the clinical features becomes important. So these are all the clinical features of pulmonary TB. Now come to the extrapulmonary TB. So in the extrapulmonary TB, there may be tuberculous lymphadenitis, where there may be discharging sinus from any lymph node. Okay, and the renal tuberculosis may occur there. Then tuberculosis of fallopian tube, endometrium may occur. Then skeletal tuberculosis may occur there. One of I mean very important is called skeletal tuberculosis. Example is the TB spine, which is also called as the Pott's disease. You will learn about the Pott's disease once you come to the fourth year in the orthopedics. Okay, there comes a short note about this Pott's disease in the orthopedic paper. Other than that, there may occur the gastrointestinal tuberculosis, the TB meningitis. There may occur tuberculoma. Okay, tuberculoma means meaning a granuloma found by the tubercle bacilli, and the pericarditis, peritonitis. Any of these infections can be caused by the TB, and this may be the clinical feature of the extrapulmonary TB. So this is all about the tuberculosis. So you should remember the pathogenesis very well, because that is a very important question both in pathology as well as in microbiology, and I have described the pathology in a very lucid way. Okay, it cannot be more simpler than this. Okay, so that's all for the first part of the tuberculosis. Next we'll talk about the tuberculosis diagnosis, and later on we'll talk about the non-mycobacterium tuberculosis, NTM. Okay, non-tuberculous mycobacterium. So that's all for tuberculosis.